Hi guys, Happy New Year. It's the start of 2026. So the new semester is about to start, or a quarter if you guys are on the quarter system. Hope you guys are having a good winter break, or if you guys are already started school, good luck. So today we're going to be doing a very quick review on pain in the intro to nursing, kind of like health assessment type course, and then we'll be going over some practice questions that cover the material from the previous few videos. So this is mainly for an incoming nursing student in their first semester, and of course my cat wants to chime in. So let's first define pain, right? What is this definition? So it is oftenly referred to as the fifth vital sign, and it is a subjective one. It's not objective like the others where we can say, their vital is 97 degrees. It's subjective, right? So a phrase that you might hear often is, it's whatever the person experiencing says it is. This is the exact wording that I used when I was answering my interview questions, for a job, and I just said, hey, pain is just whatever the person experience says it is, right? And as a nurse, it is important to manage pain and relieve suffering. It's our legal and ethical duty, okay? Now, some professors might be mean and have a trick question and say that one of the choices would be, when your patients are in pain, one of the things that you can talk to them about when setting goals for their plan of care is to have no pain. Now, that's such a minor difference in wording, but the fact that they say no pain is very unrealistic. So make sure you guys don't fall for that like I did one time in my exams. There's usually going to almost always be some pain with any type of invasive procedure, right? So it's not, expected to have no pain, okay? So we have some assessments that we can use to determine pain, mainly this acronym LOUDCARTS and PQRST. LOUDCART stands for location, onset, understanding, duration, characteristics, associated symptoms, rising relieving factors, and then treatments and severity. Okay. It used to be old cards. They did not have the U here. This was added pretty recently, I would say, and it would help see if the patient kind of had an understanding of what was going on, right? Like, so if they come in with a wrist pain, you can ask them, do you have any idea? You ask their location, they're like, it's my wrist. Onset, well, it's been happening for quite a while, maybe since 3 years, right? When did it first start? Duration, they could say it's, it comes and goes, or it's just always there. Characteristics could be it hurts, more at this time of day, hurts less when I do this, when I rest. Associated symptoms is, redness, inflammation of the joint. Rising and relieving factors, things that make it feel better, is resting it. Things that make it worse is using it a lot more. Treatments tried, it can be NSAIDs, right? Tylenol. And then severity, they could be it's a 6 out of 10, right? And then when you finally get to the very end, where you talk about understanding, they're like, yeah, it's probably my arthritis is flaring up, or something along those lines, okay? PQRST is basically the same thing, but it's just a different assessment scale. So you can use whichever one that you prefer, but I've always used LOUDCARTS because that's the main one that I was taught. But in the end, they both try to pinpoint, locate the pain, find out what's really happening. You're basically gathering data regarding the chief complainant. Now, you have some assessment tools. Okay, so this is the Wong-Baker's face scale, okay? It's usually for children, but you can also use it for patients that are non-verbal, non-communicative. Sometimes, on med-surg floors, you have confused patients that can't really verbally say what they're going through. There's another scale that you'll see in hospitals like CNPI, but Wong's-Baker is also an acceptable substitute. But then again, keep in mind, this is not as accurate as maybe perchance a person may be telling you, okay? The numeric rating scale is the most common. You've probably seen it or heard it or used it yourself all the time, even if you haven't like meant to use it. You know, you'd be like asking how bad is your pain on a scale of 0 to 10, right? And generally, like 3 is considered the high end of like mild pain, 6 is the high end of moderate pain, and 7 to 10 is considered severe pain. So you'll often see, for example, oxycodone prescribed like 5 milligrams for 4 to 6 pain, and 7 to 10 for will be the scale used for 10 milligrams. So the amount of oxycodone you can give would vary between these two scales. So if your patient's like, I have 7 out of 10 pain, you probably should go with the 10 milligrams. Obviously, keep in mind that some patients may know this, so they're just always going to give you a number like 8. But, that's neither here nor there. It's our job legally and ethically to try to manage it, right? I mentioned a little bit about that story when I did my interview video. Okay, so let's go over the types of pain, okay? So there's nociceptive. It's generally described as dull, an ache, a type of throb, okay? It's usually pain is like induced into the body tissue, maybe from like a fall, breaking your ankle, getting your wisdom teeth out, or just like arthritis, right? So nociceptive is further divided into 3 parts. There's visceral, cutaneous, and deep. Visceral, I want you to think of like visceral organs, right? It's like the things inside your body, but not at a very deep level, such as the joints, bones, tendons, and muscles. It's like the intestine, stomach, this area. Cutaneous, like subcutaneous, right under the skin, cutaneous skin. Paper cuts is a big one. And we kind of just mentioned deep pain, like, the joint pain, back pain, stuff like that. Neuropathic is often described as sharp, shooting, and tingling. So it's this burning sensation, okay? It's usually due to damage from the nervous system, and or if it's there's something preventing the nervous system from working properly. It's not as easily predictable like nociceptive pain, right? Nociceptive pain, if you break your ankle, yeah, it's gonna hurt, right? So think of things like shingles, cancer, phantom limb pain, peripheral neuropathy. These come and go, right? They may sometimes always be there, but sometimes they may come and go. Referred pain is another type of pain here. Sorry, let me turn down the music a little because I felt that was a little loud. Referred pain is when you have pain, when you have an injury in one part of your body, but the pain is redirected elsewhere. So, for example, gallbladder injury can present with right shoulder pain. The left arm having pain or tingling is the most commonly known one, where it's like when you think about an MI, it's the left arm shooting, numbness, that kind of stuff, right? Or maybe even some pain there. If untreated, nociceptive pain can lead to chronic/neuropathic pain because of the repeated inflammation caused to the nerves, okay? So to follow up with that, we're going to talk about acute versus chronic. Acute, short-term, self-limiting, the trajectory is pretty predictable. There's the acute period where it's extremely painful, but it tapers down over time. And as the injury heals, the pain usually goes away. If acute pain is left untreated, like we mentioned earlier, it can become chronic, okay? So chronic is persistent pain. Sometimes it comes and goes. It continues for longer than 6 months, and it doesn't stop when the injury has healed, okay? So I always felt like the time period, isn't that useful on examination purposes for things like boards, but maybe for your like class exams, you may need to know the time duration. Also, just to reiterate or to emphasize some things, acute pain is sudden, and the patient will have outward signs of pain sometimes, such as like verbal, nonverbal. They're screaming, crying, swearing, and they may grimace, vocalize with like moaning. They may guard the area. So, for example, like acute appendicitis, like that right lower quadrant pain is going to be very apparent. So they're like going to be guarding. They may not even want you to touch it. They may not even be moving. They don't want to bend their right leg at all. Diaphoresis, you ever like hurt so bad you started sweating, like stomach flu, like sometimes you just start sweating because of the pain. Change in vital signs, that's also there, and that's to be expected. So when you take a patient's blood pressure, don't be surprised when you see like elevated heart rate, elevated BP, and all that stuff, and increased respiratory rate, right? Okay, now elderly adults. They often get prescribed medication at a rate 3 times higher than the general population, and they're also less likely to adhere to the directions on medication. Whether that is due to education, barriers, financial barriers, other like socio-economic determinants of health, they all put older adults at greater risk for adverse drug effects. Okay. And the physiological reason behind it is that there's decreased liver metabolisms and decreased renal excretion. So your liver and kidney play a big part in filtering the medications from your system. And since the body, gradually doesn't work as well, it also affects how quickly the drugs leave your body. So they tend to stay in the body for an extended period of time, longer than they should be. Okay. So, what dose and what rate should you administer medications for older adults? The general rule of thumb is go low and go slow, okay? So, especially things like with antidepressants, SSRIs, things like this, you shouldn't be like also full dosing people right away, even with a young, healthy patient. These things need to take time for it to work effectively, right? They say like 3 weeks for like serotonin. SSRIs, right? So, just be extra cautious with older adults. Some big concerns with pharmacological pain meds with the elderly are like the oversedation, the motor vehicle accidents, cognitive impairment, memory loss, delirium, stuff like that, right? Because it stays in their body longer. So, non-pharmacological pain management, there's a bunch. These are usually pretty easy to recognize on a test because I just think of like things that aren't drugs that people like to do that is either distracting or relaxing and calming. So I'm not going to read them off because it's, pretty self-explanatory. All right. So, good luck to everybody who is taking school or like classes this semester, and now we're going to move on to some practice questions. Okay, this first question is a priority question, okay? If you guys need, for the sake of time, I'm just going to keep going, but you guys should pause if you guys want to take some time to read it, okay? I'll just count down like 3, 2, 1, and I'm going to show you guys the next question, okay? And these types of questions, side note, are also very popular on the NCLEX, these priority questions, okay? But anyways, that should be enough time, even without pausing. So 3, 2, 1. You want to see the patient with obstructed airway, right? ABC is your priority of care, right? And the other stuff, it's, it is important, but this one is the most severe, right? You want to think who's going to die first, and it's this person. Okay, the second question is a patient who came into the ED with a diagnosis of TB. What is the necessary isolation precautions for this patient, right? So remember the acronym, okay? If you don't remember, go back to the past videos and watch, okay? 3, 2, 1. Airborne. So the acronym in question is MTV. On air with MTV, like the old show, okay? And then the T stands for tuberculosis. Words are difficult. I didn't get much sleep last night. A patient's vital sign for blood pressure reads 76/54. Calculating the mean arterial pressure, the MAP, are they getting enough perfusion throughout their body? Yes or no? I'll give you some time to get some pen and paper or a calculator, and I'll show you the answer in 3, 2, 1. I didn't check the math on this one, but the previous TA said it's 61, and that's what they go by. I know some places sometimes say 65 to 60, like, that's the range, but either way, just go with whatever your professors say. Question 4. The volume of blood pumped from the left ventricle per minute is called apical pulse, cardiac output, heart rate, or peripheral pulse. And I'll show you the answer in 3, 2, 1. It is B, cardiac output. The reason is because we're asking about the volume, okay? So reread the question carefully if you got it wrong. It's the volume of blood, right? So that happens a lot in nursing school. They love to trick you guys with just these little tiny questions. If they said, like, what is the amount of times the heart beats per minute, right? Then that would be like heart rate, right? But no, they're talking about volume here. Heart rate's the number of times, beats per minute. Apical pulse is the pulse count that you listen at the apex of the heart, which is like, down near like the fifth intercostal mid-clavicular line, that area near the apex of the heart. And peripheral pulses are the ones that are like, at the periphery. So like, the radial pulse, the pedal pulse, the dorsalis pedis, foot and ankle. Legs and hands, sorry. Okay. Next question. A patient comes in with a BP of 150 over 100. What stage of hypertension is this classified as? Elevated, stage 1, stage 2, and D, hypertension crisis. And I know if you guys were paying attention in my previous videos, I talked about you can't just say a diagnosis of like hypertension based on one reading, but let's say that this is already diagnosed. This question wasn't written perfectly, but for the sake of, this question, let's just say that, they already have hypertension. Okay, it's already diagnosed. What stage is it? I'll show you the answer in 3, 2, 1, answer time. 150 over 100 is stage 2. The systolic is 140 or greater, and diastolic is 90 or higher. And remember, it's and or. It does not need to be systolic, like, it could be at both. The diastolic high and the systolic is high, okay? Next question. A doctor has given orders in EPIC to do an orthostatic vital sign for a patient that has been on a beta blocker. For, you new nurses or nursing students, a beta blocker reduces your blood pressure. This is what an antihypertensive medication is for the past month. What is the proper way of performing this task? Sorry, I feel like I have something caught in my throat. Jeez. Let me move my mouse so I can make my thing transparent. Okay, anyways, 3, 2, 1. Okay, so they're going to rest supine for 3 minutes, take the BP, have them sit up, retake, okay? So, another thing is to keep in mind is that they don't always have to go from supine to sit to stand. It could just be 2 sometimes if they can't tolerate it, and it is what it is. We're not going to risk the safety of our patient to do this test. I even done that with the doctor. I'm like, hey, they're so weak and unstable. I can only do like supine to sitting. Like they're not walking, dude. I didn't say dude, but you get it. All right, next question. Patient was giving contact information for a support group regarding cancer and chemotherapy. This type of health prevention is known as primary, secondary, and tertiary therapeutic. I kind of don't like the way this question was written because I don't think it's exactly health prevention, but you should let me know your best guesses in 3, 2, 1. Tertiary. So the rationale is support groups are a part of the third type of health prevention because the disease has already happened to the patient and we're just trying to get them rehabilitated back to normal. So the reason why I don't really exactly like this question is because it's not exactly clear. Like, for example, if I said a patient had stroke and we sent them to PT, what type of prevention is that? I think that's more obvious that I'm trying to clue you in that this is like a rehab type thing, right? But, for this purpose of this, video, let's just go with whatever the person wrote for this. All right. Select all that apply. Everybody's favorite type of question. I'll give you some time to read it through in 3, 2, 1. I'm going to show the answer here. It is facilitation, reflection, empathy, and confrontation. I remember confrontation being a very controversial answer, but that's just what it says in the book. And, you know, again, this is one of those low yield questions that I feel like aren't that important. But if you really want to, like, you know, be dead set on it, you can look it up in, like, Jarvis or Perry and Potter 9th edition, I believe, is the textbooks. What is the Nurse Practice Act? A lot of legal stuff. I'll give you some time to read through it. 3, 2, 1. It is B. Again, like I always feel with these legal questions, good to know, but will not make or break you as a nurse. Like, how hard is it just to do, like, the right thing, right? Like, don't be dumb. Like, right? Use have common sense. You know, take care of your patients, do the right thing, be safe for you and your patients, right? Like, I don't know. I feel like these questions are whatever. Okay. Teaching a patient to use an incentive spirometer would lie under which nursing care level of priority? Primary, secondary, tertiary, metaphorically. 3, 2, 1. It is tertiary. It is tertiary because it is not a life-threatening thing. It is not something like pain, which is usually secondary, or like a change of mentation. It is tertiary, which is usually where they put things like education, time to answer questions, stuff like that. That's like a third level of priority, okay? The 11th question, almost done, guys. 2 more, 11 and 12. A patient is admitted to the med-surg from the ED. A full head to toe is done, and it's found that the patient has 26 breaths per minute, intercostal retractions, and SpO2 sat of 92. The nurse's next action is to A, contact a doctor, apply oxygen via nasal cannula, and obtain the order later, perform a focused pulmonary assessment, or continue on with the patient's blood pressure and other vital signs like nothing ever happened. Oh, sorry, I didn't count down. 3, 2, 1. So you do a focus assessment because the patient seems like they could be in respiratory distress. You don't know if the patient has COPD, which would make their SpO2 range fall normally within, you know, that number. But so you need to do a little deeper diving and see if they have a history of COPD or things like that. You won't immediately apply oxygen in this situation because in the event that they do sit at 92% naturally and they do have COPD, you can knock out their respiratory drive with such a high flow of oxygen, okay? And if also the patient is in respiratory distress, I think finishing up your vital, like your temperature and blood pressure, that can wait. Save the patient first. There's no point getting vital signs for a dead patient, right? Like, or will be dead. So you gotta save them first. But make sure you're safe. That's why you have to do assess. This is where the nursing process comes into handy a lot. You'll see this a lot of you see a lot of questions like this on the NCLEX. So I go by ADPI, right? Like always assess first, then do the nursing diagnosis, then plan, you know, then intervene, and then educate. Like, but probably the only two like relevant ones are like the intervening one and the assess one. But you always want to assess before you intervene, unless the question explicitly says that you already performed an assessment, right? And it has to be a good one, not like this question where it just said, you know, what was it, like it was just vital signs, right? That's not totally done because I need the bigger picture. Like I need to know if they have SpO2, right? I mean COPD, sorry, not SpO2. Jeez. Question 12. Nurse Jenny is assessing a patient admitted to the ED with edema of the legs and crackles in the lungs. During her assessment, she cannot palpate pedal pulses. Her next action is to A, have the patient take a little lap. B, use a Doppler, call the doctor, chart a 0 for pedal pulses. Your answer choices are up in 3, 2, 1. Use a Doppler. For the love of God, please do not do any of the other options. Like, well, maybe A is like not so severe, but like if you call the doctor without having tried using the Doppler first, I just hope that your doctor is kind and understanding and doesn't bite your head off. If you chart a 0 for pedal pulses and you haven't tried a Doppler, I also hope that, you know, your nurse manager will spare you and be kind. But you cannot just willy-nilly just say 0, you know, like, you have to at least try something, okay? Anyways, that's all. I guess the questions took a little long, but hopefully this was helpful and beneficial to you guys, okay? Happy studying, and once again, Happy New Year.